And in trans-abdominal, of course, it is 10 millimeters. And the heart rate is less than 70 beats per minute, it's definitely abnormal. A large yolk sac, more than 6 millimeters, then there is a high risk of something going wrong. Then you see an amnion, right? So the developmental process, the chorion is formed first, the amnion is formed next, and the fetus is formed third. This information we use for in multiple gestation to find out chorionicity and the splitting of the splitting of the zygote in multiple gestation. We'll come to that later. But when you see an amnion and you don't see an embryo, it is already a failed pregnancy. Because when the amnion is present, the embryo must be seen. Because you know that the bilaminar germ disc, it is around that the amnion is actually forming. So if the amnion is formed and there is no germ disc, then obviously it is abnormal. And decreased chorionic fluid. Sometimes you can see the fetus is tightly packed so early in pregnancy, there is no chorionic fluid at all. So that also can result in a failed pregnancy. Right. So the mean sac diameter greater than 8 millimeters without a yolk sac. The mean sac diameter greater than 16 millimeters without an embryo is always a failed pregnancy. And these findings are independent of gestational age or symptoms. So the patient, you may say, the patient has no bleeding at all. She is absolutely asymptomatic. But I am seeing a sac 16 millimeters in size and there is no embryo inside. That means there is no point in waiting in this pregnancy. It is already a failed pregnancy. Right. See, for example, here, this sac is too large and I don't find any intrauterine sac contents. So this is a blighted ovum and I don't think I'll wait for it anymore. Now here's a fetal pole which is quite large and I don't see a fetal heart. And you can see an abnormal increase in the fluid around. This is also a failed pregnancy. Here you can see decreased chorionic fluid. The fetus is completely tightly packed. So also likely the fetal heart may be present, but this pregnancy is likely to end up in a negative outcome. Then you can see a large yolk sac, or you can see a calcified yolk sac. Sometimes calcified yolk sac can proceed to normal pregnancy, but a large yolk sac you have to watch out whether it's having problems. Here you can see fetal bradycardia. Now it is preferable, I deliberately put this picture because never use Doppler in early pregnancy. Because Doppler has got very high energy output, you switching on a Doppler like this and you can actually see the fetal heart becoming bradycardic when you put the Doppler. So it's not advisable to put Doppler so early in pregnancy. You wait till about 11 weeks plus to use Doppler. You can use egmore to do the cardiac study of the fetal heart rate. Okay, just to give you a few examples to put things in perspective. 27 years primary, no risk factors. Fetal pole is 10 mm. LMP gestation age is 7 weeks 0 days. According to CRLs is 7 weeks 4 days. The assigned gestation age is 7 weeks. So you assign gestation age at this period if you have the opportunity. Here's another patient where she's got irregular cycles. Menstrual age is 10 to 11 weeks. CRL is only 5 millimeters. So we said 5 millimeters plus 42 is 47 days. Okay, so she, according to that, is about 7 weeks plus according to CRL. According to menstrual age, is 10 to 11 weeks. So we will change our dates at this point. When we change our dates at this point, remember, in subsequent scans, never go and reassign dates. The first scan you do and you change your dates, those dates stick for the rest of the pregnancy. But every time they go to a different person, they put the CR, I'll show it to you on the machine, where the machine will give you a gestational age and it will also give you an EDD. The person who reports will simply copy that and put it in the report without knowing what's happened in the first scan. So every time the patient goes through a scan, they will get a different EDD. So it's your responsibility to see that only one EDD is given, that's the earliest one. So here, for example, CRL menstrual age 9 to 10 weeks, CRL 2.3 centimeters, 8 to 9, according to CRL 8 to 9. Now this is right on the border. Then sometimes we would like to, this is just 1 week difference. According to that, it's 9 to 10. Here you can see 8 to 9. So this 1 week is within the variability limit. If she has irregular cycles, I would prefer to change the dates now itself. If she has absolutely normal cycles, she's very sure of it. Or they have done, for example, IUI or an IVF pregnancy, then I would just like to wait on it and see how the baby grows. Right now, Here you can see some of the components. This is where we'd like the sac to be implanted. Now, uterus larger than the period of amenorrhea, in pain in early pregnancy, intra pregnancy with vaginal bleeding. Then uterus greater than the period of amenorrhea, you'll have multiple pregnancy, molars, fibroids, ovarian masses. Sometimes pelvic kidneys have been reported as uterus appears larger than days. When you do the scan, uterus is normal, but there's a pelvic kidney there. So, the issue of multiple pregnancy, if you come across multiple pregnancy and you had the opportunity to do an early pregnancy scan, we have to cash in on that because enormous amount of information is obtained as far as multiple pregnancy is concerned in early pregnancy. Well, before 10 weeks, there is a little bit of an issue regarding calling it the number of fetuses. Supposing I see one sac, one gestational sac at 5 weeks. I cannot say it's a singleton pregnancy because when I see it at 7 weeks, it could be a single sac with 2 fetuses inside, monochorionic diamniotic or monoamniotic pregnancy. So, calling or declaring a multiple gestation before 10 weeks, you have to be extremely cautious. One. Second is, before 10 weeks, even if there are 2 fetuses, for example, at 7 weeks, by the time you come to 10 weeks, it may actually become to 1. It can spontaneously reduce to 1. That is why the number of fetuses is usually declared on seeing distinct fetal cardiac activity. It is not the number of sacs. It is not the number of membranes which you see. It is the number of fetal cardiac activity. That is, declares the number of fetuses. Right? That's important. Secondly, when you do in early pregnancy multiple gestation, we look for the chorionicity, and chorionicity has to be declared early in pregnancy to be accurate. We'll come to that when we talk about the 11 to 14 week scan. Now here is an early pregnancy with a lot of cystic spaces, highly suspicious of a molar pregnancy. Right? It can also be diagnosed. Here you can see a large fibroid with pregnancy there, and here you can see a dermoid with pregnancy, a large dermoid with pregnancy. And here, as I said, a pelvic kidney along with pregnancy there. Now, patient comes with bleeding in the first trimester. What do? And the patient always wants to know why she's bleeding. And by doing a scan, it is possible in many cases to give a reason for the bleeding. In some cases, we may not be able to assign the reason. Now, we look for small implantation bleeds, subchorionic hemorrhage, or there's a bichorionic uterus with desiccal reaction in non-pregnant horn in the sac and one horn. Here you can see a small bleed which we call as implantation bleed. Implantation bleed is very, very common. It's very common, more common than we think. If you start looking for it, you'll find it in a lot of patients. Sometimes they may come to you with a little bit of spotting and that triggers the alarm. Fetus is viable, a small amount of hemorrhage there. At least we know the reason for her. We need to reassure her that things are under control, no need to worry about it. But when the subchorionic bleed becomes very large, as you see here, but still fetus is viable here, or I can see extremely large subchorionic hemorrhage, there is a high chance that the baby may not make it. But even then, as long as the pregnancy is viable, we just wait and watch. We will take preemptive steps. Some of them with a large subchorionic hemorrhage who have gone to the second and third trimesters may end up in an intrauterine growth restriction, which we have seen. Then we talk about pain in early pregnancy. The other reason is ectopic. You have inevitable abortion, incomplete abortion, sometimes hemorrhagic cysts in the ovary or ruptured corpus luteum cyst, which can cause pain, or there's ovarian torsion. Sometimes it can even be an appendicular mass which is causing the pain. When we talk of ectopic, we know that 60 to 70% is the site is in the ampullary region and 20-25% in the tube here. We suspect ectopic pain, bleeding, and adnexal mass. The adnexal mass identification with ultrasound is the key. You must have a positive pregnancy test, amenorrhea, and if the beta HCG is more than 1000, I'll tell you about that. There are 3 distinct groups which we see in ectopic. The first group with life-threatening features of hypovolemic shock, collapse. This patient, if you wait for the ultrasound person to give appointment, the patient will die. So there is no ultrasound required. You go and do, maybe if you have a machine in your labor ward or somewhere, theatre